Norepinephrine, like epinephrine, but missing that beta 2, right? And so that's significant. So the good thing is that you can increase the vasoconstriction and you can increase the heart rate. The bad things is that this stresses the heart, right? I mean, it's going to run for a while, but eventually it's going to give up. Eventually you're going to create lactate. Eventually the heart is going to, it's working hard and it's trying to consume more oxygen and it's probably not getting enough. So I put up here just a couple. Believe it or not, there's not a whole lot out there with norepinephrine. But a couple cases where it was a TCA, they were started on dopamine, they were hypotensive, they gave them norepinephrine, they got better. And then this olanzapine case was, again, the same principle that hypotensive, they figured with alpha-1 blockade from the olanzapine, norepinephrine would be a good choice with alpha-1 agonism, and the patient got better. So it's going to work on both those receptors, beta-1, alpha-1. It's going to increase that cardiac contractility, and it's going to vasoconstrict. Isoproterenol. Anybody recommend this? Or anyone here, a patient on this drug? That's probably good, actually. But this drug was used a lot before beta blockers, right? You see beta-1, beta-2 agonism. And so people thought, well, that makes sense. We'll give them a beta-1 agonist. It'll overcome the blockade, and we're going to make this patient better. And so that could happen. The bad thing is what you probably already realize if you have beta-2 agonism, is you may vasodilate that patient and they may become more hypotensive. And they found that high levels would even cause dysrhythmias. And this is just one study I put up there where they actually looked retrospectively at cases and found when they compared epi, dopamine, glucagon, and isoproterenol, that isoproterenol was the worst at improving heart rate and blood pressure. So if it works, it's going to work on that beta-1, it's going to increase contractility, but it may actually vasodilate. So hyperinsulinemia, euglycemia, or HIE, sort of like a little dressing there on your salad, right? A little cabbage. It's got a lot of potential mechanisms of action. You may convert this from an aerobic to aerobic state, right? You may clear these bad endpoints of metabolism like lactate. It may increase intracellular calcium. That hypokalemia may actually be somewhat helpful for the high-dose insulin. So the good things are that it may increase your cardiac contractility without increasing oxygen demand. So it's going to provide a substrate, and it's going to make a more healthy heart rather than working it so hard it's going to eventually wear out. The bad things, of course, as with insulin, you're going to have hypokalemia, you may have hypoglycemia, but I think we've all probably seen in the literature and through experience that this is rarely a significant issue. And there, as you can see, 38 through 42, a lot of reviews on this. So these are excellent reviews, great to read about the mechanism and treatment. And one was even a safety study. It was only 7 patients, but they found that they didn't have any significant, only one of them had hypoglycemia less than 60 with no clinical significance, and there were no dysrhythmias from hypokalemia. And you've probably heard about these in the past, but it works in the dog model with propranolol. It was much better for survival when compared to epinephrine and glucagon. In the pigs poisoned with propranolol, it was better than this combo of epi and vasopressin. And even in a severe cardiac arrest case with nebivolol, they used high-dose insulin and the interlipid, and the patient survived. So there may even be a role for the combination of both those. So the insulin, right over here, it's going to come in. It may go through all those methods that we talked about, and it's going to increase contractility. Sodium bicarb. So this is often controversial. You'll probably not meet anyone in the same row that has the same opinion about bicarb, but this is in the setting of the TCA, right? You've got conduction abnormalities, you've got sodium channel blockade, or it could be any other sodium channel blocker that this is blocked and you need to reverse that because you're seeing hypotension and the prolonged QRS. So it may be a little bit more sodium than bicarb, but honestly, both parts are probably important. And the great thing is you have an antidote with both. And so the good things is it's in your crash cart, it's easy to recommend, doctors can get it and push it and do good things with it. The bad things are potentially just making them too alkalemic, where they can have dysrhythmias, they can have seizures, and all the electrolyte abnormalities such as hypokalemia, hypocalcemia, hypophosphatemia, hypernatremia as well. And I've certainly seen a case of a patient that was left on a bicarb drip and developed hypokalemia from the shifts from the alkalemia and had torsades, so had prolonged QT, just what Dr. Bryant was talking about, and survived, but it was really iatrogenic. It wasn't the overdose that caused that. And so that's why sort of my viewpoint on this is that you want to bolus them until they're better. And I've definitely seen this in TCAs, in cocaine, known sodium channel blockers, where if you catch them in that moment where they're actively dying and you see the prolonged QRS on the monitor, on the EKG, and they're hypotensive, and you bolus them until that resolves. And it often will make them quite alkalemic, which may be helpful, and it's going to give them plenty of sodium to treat that conduction blockade. I did want to mention a couple of studies here. This is a nice review article about sodium bicarb. It's been used in a bupropion case and even a flecainide case where they had prolonged QRS. I wanted to just mention this, somewhat tangential, but in looking at the literature, there are a couple of cases of Brugada syndrome, which I'm going to show you what that is. One where the sodium bicarb reversed it and one that it didn't. And then even a case of Takotsubo syndrome, or that, which I'll talk about too. So this Brugada syndrome is when you actually have an innate problem with your sodium channels, and it can be manifested when you take a sodium channel blocking agent, and this is what you see. It's basically in these precordial leads, which Dr. Bryant talked about, you'll see ST elevation and a right bundle branch pattern. And as I said, in one of those cases, they gave sodium bicarb and reversed it. So the Takotsubo syndrome is from this a Japanese word that describes this pot, and this is when you have your heart, it's thought that it has increased catecholamines and you have total left ventricular dysfunction, and it looks like this pot on your cardiac cath because you have ST elevation or you have T waves that are inverted. You go to the cath lab because they think you're going to have an MI, and it's not. But there was a case where it was a TCA overdose, and the patient developed chest pain after that, and they wrote up that this, maybe that was the stressor that caused this syndrome. So back to our regular scheduled program. If we give sodium, we're going to go through that blockade, and we're going to increase cardiac contractility. Levosimendan. Has anybody heard of this drug? We got a few, right? So this is a drug that's not available in the United States, but has been used in Europe. As you see, this human case, 53 here. So this is an interesting drug. So it's actually in the literature, so you can read about it. It helps calcium bind to troponin C, and then that helps contractility in the heart. It actually also does this, which could potentially cause vasodilation. So the good of that is that you can increase the contractility. The potential bad is if you vasodilate, just like maybe epinephrine or isoproterenol, you're going to have more of a problem. And so a few studies here with some rats poisoned with verapamil, they gave them levocimendin versus calcium versus levo all by itself, so levo by itself, calcium by itself, or levo plus calcium. And they actually found that the calcium by itself was the best in this scenario. And this one with rats poisoned by verapamil, they found that the levocimendin could increase contractility but would not necessarily improve their blood pressure to too much of a degree, which kind of makes sense when you consider the mechanism. So similar results with levocimendin and verapamil in the animal model, and they found that in this last one with propranolol that they actually, levocimendin was better at contractility than dobutamine. So if we give levocimendin, here it's going to increase calcium binding of that troponin, going to increase this contraction here, and you're going to get improved contractility. But remember, you may have some vasodilation. So I don't know, be prepared. This may be a drug that we will be using in the United States. So just a little bit about machines. I think more and more we're going to, it's kind of like our salad shooter here. If we can make a machine that can make you live, that we're going to put it in you, right? And so pacemaker, just put it going on. There are numerous cases of all this stuff. Has anybody actually ever convinced someone to do this for them? Yeah? I'm impressed. Because I think this is hard, because you got to talk to a surgeon, right? You got to talk to a surgeon who doesn't really know about overdoses. And certainly if you hook them up to one of these things, like a cardiopulmonary bypass or intra-aortic balloon pump, and you wait till the drug's gone, they're probably going to get better. And that's probably why that's all you see in the case reports is the ones that survive. So of course that may work. The bad things may be is that there are complications with these. If you put in a transvenous pacemaker, you could cause a pneumothorax, you could perforate the vessel, you could have bleeding issues. All of these things can malfunction. You use heparin with many of these, so they definitely have their potential downsides. The only study I wanted to mention was this one right here, sort of looking at the idea that you don't want to do a transvenous pacemaker for digoxin poisoning. So anybody ever heard that? You're not supposed to, or it's potentially dangerous if you start poking that heart with a sensitized myocardium with a transvenous pacer. And so these people looked at humans that were dig poisoned, and they looked at the ones that had the pacers, and they looked at the ones that didn't retrospectively, and they found that there were no increased dysrhythmias with them. So maybe it isn't so bad. I just wanted to show you some of these